بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are going to start the third part of the pediatric imaging, pediatric chest imaging. We have finished the first part dealing with the anatomy and techniques, and the second part, which dealt with the focal pulmonary lesions. You remember we have divided the pulmonary pathology into focal and diffuse, and we have said that there are focal main subtypes, which are the pulmonary nodules, pulmonary masses, pulmonary patches, and the pulmonary cavities. We have finished in the second part with the pulmonary nodules, which are well-defined lesions less than 3 centimeters in diameter. And also we have finished with pulmonary masses, which are well-defined lesions more than 3 centimeters in diameter. In this part, we will deal with the remaining two issues, which are the consolidation or the patches and the cavities. Then patch opacity means that there is a pulmonary lesion with an ill-defined borders that is containing air bronchogram. And by air bronchogram, we mean that there are multiple linear radiolucences within an area of opaque lung. These linear radiolucences represent air in patent bronchi on the background of consolidated lung. Then in the differential diagnosis of these lesions, we have two, the pneumonic consolidation and the infarction. You know that there are a lot of lesions that can produce lung consolidation, and most of these lesions belong to the diffuse lung pathology, not to the focal lung disease. And in the focal lung disease, we have only two, which may produce focal areas of consolidation containing air bronchogram, and these are the pneumonias and the infarctions. Of course, you know that pneumonias are far common than pulmonary infarctions in the clinical practice. And these are different types of pneumonic consolidations by plain X-ray. In this case, you see a total consolidation of the right lung showing air bronchogram. You see that the costophonic angle is more or less patent, denoting absence of associated pleural effusion. And in this example, which is very commonly seen in the exams, there is a consolidation collapse of the left lower lung lobe, which is seen usually behind the cardiac shadow containing air bronchogram as well. And here you can see an example of right upper lobe consolidation bordered by the slightly elevated horizontal fissure. And this is a consolidation of the left upper lobe, and you see air bronchogram inside the lesion. Then usually you do not need the help of CT to diagnose pneumonia, since the clinical manifestations are evident and also the X-ray findings are enough for the diagnosis. But whenever you have a CT scan for a pneumonic consolidation, and you can see this is an example of consolidation in the middle lobe with faint air bronchogram inside. And this is also a consolidation in the middle lobe. And you know that this is middle lobe from the frontal X-ray by the silhouette sign. And the silhouette sign means that if there is a lesion or an opacity which is adjacent to the heart, it will mask the cardiac border. And you know that the heart is an anterior structure, then the opacity which masks the cardiac border should be anteriorly located. And on the right side, the anteriorly located lobe is in the middle lobe. Then you know that this is middle lobe consolidation, because you cannot follow the cardiac shadow through the opacity, meaning that the silhouette here is positive and the opacity is adjacent to the heart. Then there are a lot of complications associated with pneumonia, starting by the parapneumonic effusion, then the emphysema, the bronchopleural fistula, nematoceles, pneumothorax, abscess formation, bronchiectasis, and finally what is known as the cavitary necrosis complicating pneumonia. Starting by the pleural effusion, and frequently you are not able to radiograph a child in the erect position. Sometimes you have an X-ray in the supine position, and in this case, if the patient had effusion, the effusion will spread underneath the lung, and it will give this very characteristic appearance, which is veiling of the hemithorax. Then, if you know that this is a supine radiograph, then you know that this should be due to the presence of pleural effusion. And pleural effusion is usually associated with pneumonia due to the spread of lung inflammation to the pleura. At first, the effusion is usually sterile with low leukocytic count, and after that, it will be inflamed, and you will see evidence of inflammation in the effusion. Then look at this case. This is a male child with a consolidation in the left lung. And if you look carefully, you can see the cardiac border through the opacity. That's to say this opacity is not adjacent to the heart. It is not anteriorly located. It should be posteriorly located in the lower lobe. Then one day later, the follow-up chest X-ray showed marked increase in the opacity and obliteration of the costophrenic angle, denoting that the opacity is associated with pleural effusion. But this is a position which is known as the decubitus position. We put the patient on his side, then we put the X-ray tube in front and the X-ray film on the back in order to confirm the presence of pleural effusion. In this position, you see minimal pleural effusion, indicating that most of this fluid is encysted. And nowadays, we do not usually go for this projection. We use the ultrasound, which is very good, very rapid, and very accurate in diagnosis of pleural effusion associated with pneumonia. Then the effusions are usually due to a spread of infection from the lung to the pleura, and effusion is usually unilateral, confined to the side of the pneumonic consolidation. And according to the literature, if you got bilateral pleural effusion, you may think of TB or parasitic infection. Then the incidence of parapneumonic effusion is about 1%, but in adults, the incidence is relatively high. And how can you diagnose parapneumonic effusion? You see a consolidation containing air bronchogram, and the ipsilateral costophrenic angle is obliterated, meaning that there is fluid in association with the inflammation. And here is an example. You see a pneumonic consolidation in the right lung base, and this consolidation is masking the cardiac shadow, denoting it is in the middle lobe. And in the follow-up X-ray, they see the development of fluid which is raising along the lateral chest wall, denoting the presence of pleural effusion. And before the development or the market development of ultrasound in chest imaging, we used to use CT scan to diagnose effusion and most of the complications of pneumonia. And this is just an image showing a pneumonic consolidation in the left lower lobe containing air bronchogram and a large pleural effusion compressing the consolidated lung. But after the introduction of ultrasound as a major tool in thoracic imaging, it has replaced most of the let's say the CT scans which were done for diagnosis of complications secondary to pneumonia. And you know that ultrasound has no radiation hazards. Ultrasound is very sensitive in detection of pleural collections. Ultrasound can be performed as a bedside technique and is, of course, relatively cheaper than the CT scans. And so you can see here if there is minimal pleural fluid, this is the liver and this is the diaphragm, and you see this is the diaphragm, and you see some pleural fluid which is accurately detected by ultrasound. And then ultrasound can detect small pleural collections more better than X-rays. It can detect or predict the nature of the fluid collection if it is sterile or infected by the echogenicity of the fluid itself. And very importantly, ultrasound can detect the presence of pleural septations within the effusion, which are very important if you are going to percutaneously drain this pleural collection. Then you see this note, which is that CT scan should not be performed routinely because of the radiation hazards for the pediatric patients, and you can use alternatively the ultrasound. Then, how can you know that the effusion is secondary infected and the effusion is now transformed into an emboyema? This will depend on the host resistance, the patient, and the bacterial virulence and the onset of medical treatment. And we used to diagnose emphysema whenever we see this by CT scan. And you see a pleural collection, and the margin of the collection, the parietal pleura and the visceral pleura are thickened and enhanced, meaning that there is an inflammation occurring in this fluid. This is a very important issue regarding ultrasound. And here you can see there is pleural collection and there are multiple internal septations, and these septations cannot be detected by CT. Then if you are going to drain this collection and you don't know about these septations, and you got minimal results because of the localization of the fluid. Then this is multiple images from an endoscopic release of some of the pleural septations and the drainage of the pus with re-expansion of the related lung. Then the pleural effusion associated with pneumonia starts by being a simple effusion with clear fluid and low white cell count. And after that, the fibrinovirulent effusion, there is deposition of fibrin in the pleural space, leading to septations which are at the beginning incomplete. And these septations may not prevent the free flow of the fluid, and then you can easily drain the fluid percutaneously. And this is also a good example in by ultrasound. You see the effusion with multiple internal septations, and by CT you see the effusion and you cannot see the septations. Then ultrasound, besides its benefits, it can also detect lesions which are not usually detected by CT, like these internal septations, which will affect the outcome of the percutaneous drainage of the fluid. And this is a CT scan of a patient with pneumonic consolidation in the right lower lung lobe, showing air bronchogram with the parapneumonic effusion. And sometimes you get multiple loculi within the effusion seen by CT, which is an indication that this effusion is secondary infected. And here you see bilateral pneumonic consolidations in the lower lobes, and you see pleural effusion, which is a little bit more on the right side. And then the third stage of pleural collection after the sterile stage and the fibrino, the presence of fibrin bands, then the organizational stage where you develop fibroblast infiltrates the pleural cavity with thick and non-elastic pleural strands, which will result in loculation of the pleural fluid and trapping of the underlying lung. Then the follow-up or the sequence of development of these strands in the pleural fluid are better followed by ultrasound rather than CT. And here you can see a pleural collection with complete strands within the collection, transforming it into multiple loculi. Then other complications which are rare in children of this collection include the development of bronchopleural fistula and the spread to the lung, forming a lung abscess or perforation into the chest wall, which is known as empyema necessitans. Then here is a chest X-ray showing opaque right hemithorax with obliteration of the costophrenic angle, denoting the presence of pleural effusion. By ultrasound, you can see the septations within the effusion. By CT, you can see the effusion and the underlying consolidation. Then whenever we see internal septations within the collection, the pleural collection by ultrasound, we know that this is an organizing empyema, and we should consider that percutaneous drainage may show unoptimal results because of the multiple loculi in the pleural fluid. And sometimes you got air within the pleural, the infected pleural collection, and this is what we call the biopneumothorax. And here you can see that the parietal pleura and the visceral pleura are thickened and enhanced, denoting that this is an empyema. The presence of air within the empyema is an indication of the development of biopneumothorax. Then sometimes with the development of the pleural effusion, there may be a need to drain just this effusion, especially if it is infected. Then if there is any indication that effusion is not secondary to infection, a small volume is aspirated for cytological analysis, and according to the results of cytology, we may insert the chest tube. And this is an example, and you see there is a large right-sided pleural effusion, and after insertion of the chest tube, there is almost total resolution of the effusion, but later on the effusion started to reaccumulate again. Then the aspirate of the pleural fluid may contain lymphocytes, and in this situation you may think of the presence of TB, and you should also exclude the possibility of an underlying malignancy. This is a parapneumonic effusion which is compressing and collapsing the left lung with a shift of the mediastinum to the opposite side. And as I have mentioned, that the development of lung abscess or the bronchopleural fistula or empyema necessitans are rare complications in children. This is once more an ultrasound of an empyema, nicely demonstrating the encysted collection with multiple internal septations. Then when to suspect the development of bronchopleural fistula, which is more seen in adults than in the pediatric age group. If you see a pleural fluid, and at the time the pleural fluid developed air inside, and we have three possibilities for air developed in a pleural collection. Number one is iatrogenic due to insertion of an aspiration needle or an intercostal tube. Number two is an infection with gas-forming organism. Number three is the development of bronchopleural fistula. In adults, if the iatrogenic cause has been excluded, think of bronchopleural fistula rather than infection with gas-forming organism, which is considered rare. Then, if you have a pleural fluid with no previous interventional techniques and it has developed the air inside, think of the possibility of the development of bronchopleural fistula. And if the empyema has penetrated through the chest wall and extended into the subcutaneous tissues and may rupture also on the skin surface, and this is known as empyema necessitans, and this is commonly seen in TB and also commonly seen in adults rather than in the pediatric patients. Then we came to one of the complications following pneumonia, which is the nematocele. You know that the infection, especially with staphylococcal pneumonia, during the resolution of the disease, multiple thin wall air-filled cavities will develop in the lung, and they are known as nematoceles. And these nematoceles, as I have mentioned, they are well-defined air-filled cavities with thin margin and located within the lung parenchyma. Also, there are other causes for the development of nematoceles like the birth trauma, the car accidents, and the hydrocarbon aspiration, and in cases of eosinophilic granuloma. This is a good example of a nematocele in a case of a staphylococcal pneumonia infection. You see a well-defined cavity filled with air. The margin is thin and the cavity is located within the lung parenchyma. And this is also a case of multiple nematoceles in the right lung with a thin margin and air content. And sometimes, whenever the infection is spreaded to the lesion, there may be an air fluid level. And you remember that air fluid level in a cavitary lesion in the chest is highly suggestive of an abscess. But in the pediatric age group, an infected nematocele is more common than true lung abscess. And if you see a lesion like this, and you may think that this is a lung abscess with air fluid level, and the possibility of an infected nematocele is more better in the pediatric age group than in adults. Then this is a nematocele which is not infected. You see the thin margin, you see the air content, and the lesion is located within the lung parenchyma. And as I have mentioned that primary lung abscesses are uncommon complication of pneumonia in the pediatric age group. And this may result from the persistence of the infection, and the poor response to the medical treatment may result in the development of cavities within the pneumonia or the area of pneumonic consolidation, and this is commonly seen in cases of staphylococcal pneumonia. Of course, you see here a foreign body which has been aspirated, and it may obstruct the trachea, the bronchus, resulting in this unresolving inflammatory process. And this is an example of a lung abscess by chest X-ray and CT scan. And you see that the abscess is a well-defined lesion with a thick enhancing margin located within the lung, and it may show some air loculi or air fluid level. Then the possibility of an infected nematocele is favored rather than the development of a lung abscess. And of course, I think the difference is that the nematoceles are expected to resolve spontaneously, while the abscess uh, will need some uh, more intensive medications and so. Then one of the complications of pneumonia, if it persisted for a long time, then is the development of bronchiectasis within the underlying lung. And there was a very old technique which is known as bronchography in order to confirm the diagnosis of bronchiectasis whenever it is suspected clinically. But nowadays, you know that we can diagnose bronchiectasis easily by CT scan, and I know from my colleagues who are performing ultrasound of the chest that the diagnosis of bronchiectasis is also easy by ultrasound. In here you can see that the bronchi are relatively dilated, and this is what we call the diffusiform bronchiectatic changes. And this is a case of pneumonic consolidation, which was complicated by collapse and bronchiectasis with evident loss of the left lung volume and the ipsilateral shift of the heart and the mediastinum. And this is the old technique which is known as the bronchography, where you inject a radiopaque material inside the trachea after doing a surface anesthesia for the tracheal mucosa. Then you see the contrast material within the dilated bronchi confirming the diagnosis of bronchiectasis. But nowadays you can see the bronchi through the multi-detector CT without the need to inject contrast media or do this obsolete technique. And in this child, you see that the heart is displaced a little bit to the left side. And by bronchography, you see that most of the right lung is good, but the left lung has some bronchiectatic changes throughout all the main and the subsegmental bronchi. Sometimes the bronchography is performed via the endoscope. So you can select only the bronchus which is suspected to be diseased and inject a little amount of contrast media to confirm this diagnosis. But as I have mentioned in the 2 days, we are able to diagnose bronchiectasis by CT, which is a non-invasive technique and can give very accurate results. And here you see this is the pneumonic consolidation with air bronchogram inside. But in these two areas of consolidations, you see that the bronchi containing air are considerably dilated. And this makes the diagnosis of bronchiectasis easy. And here also you see a middle lobe consolidation, which is seen in the right paracardiac area, and the CT image showed that the consolidation contains ectatic air bronchogram. And you see that the bronchi are significantly dilated, denoting the presence of associated bronchiectatic changes. Then we have two lesions which can be associated with bronchiectasis in the pediatric age group. And the first one is the cystic fibrosis, and the second one is Cartagena syndrome. Cystic fibrosis is an autosomal disease associated with abnormal chloride transport across the cell membrane. And this will result in the decreased water content of the airway mucus, and then the mucus will be viscid. And this disease was previously known as mucoviscidosis due to the presence of the viscid mucus in the respiratory tract, and this mucus may result in plugs which can obstruct the bronchi. And after bronchial obstruction, there may be some inflammatory changes in the wall of the bronchi resulting in bronchiectasis. And the bronchiectasis are are usually and affects most of the subsegmental bronchi. And if you look to the chest of a child and you see this appearance, you got here diffuse lung disease in the form of strandy opacities everywhere in the lung. And of course, it's difficult to see the dilated bronchi throughout these opacities, but usually you need the help of CT to confirm the diagnosis. Then if you have the CT scan, you are able to see that some of the bronchi are dilated and other bronchi are obstructed by mucus plugs, giving the typical um, finger gloved appearance. And these are the bronchi which are obstructed by mucus plugs, and these are the bronchi which are dilated secondary to the bronchiectasis. And also by the facilities of multi-detector CT, you can have reconstructed images in the coronal and sagittal plane, so you have a better orientation of the dilated bronchi. You can see the bronchus along its whole course, and you appreciate that there are fusiform dilatation and sometimes cystic dilatation of the bronchi as well. The second disease which is associated also with bronchiectasis is known as Cartagena syndrome, which is an autosomal recessive condition and is a part of a major disease which is known as the primary ciliary dyskinesia. And in this disease, there is abnormal ciliary structure and function, resulting in accumulation of the secretions within the bronchi and also the development of bronchiectasis. Then the Cartagena syndrome is a triad which comprises number one, the dextrocardia or situs inversus, number two, the bronchiectasis, and number three, the presence of paranasal sinus disease. And here is the triad, which is the situs inversus, either dextrocardia alone or the presence of situs inversus, chronic sinusitis or nasal bulbosis, and also bronchiectasis. And here you see that the apex of the heart is to the right side. This is dextrocardia, and you see that the bronchi containing air are ectatic and dilated, denoting the presence of bronchiectasis. Other features within this syndrome include the telecanthus, nasal polyps, infertility in males, and subfertility in females. And these are the plain X-ray findings in patients with Cartagena syndrome. Number one, you appreciate the presence of dextrocardia, and also you can see that the air bubble in the stomach is to the right side of the midline, denoting situs inversus. Then if you look carefully in the chest X-ray, you are able to see that the bronchial wall is thickened, but many times you cannot appreciate the presence of bronchiectatic changes. I usually say that the only type of bronchiectasis that can be diagnosed from the plain X-ray is the cystic type, since you can see the cystic changes in the bronchi and sometimes you detect air fluid levels within. But the fusiform bronchiectatic changes are usually difficult to be appreciated from the plain X-ray. This disease is usually uh, uh, seen in the paracardiac areas, in the lingula and the right lower and the middle lobe. And also you may get some mucus plugs within the bronchi, giving the finger and glove sign. And also you can see some consolidations. Now we came to the last complication of the pneumonia, which is known as cavitary necrosis. And this cavitary necrosis means that a patient has developed the pneumonic consolidation that is rapidly developing internal cavitations. And this is attributed to, as the literature say, the thrombotic occlusion of the alveolar capillaries will lead to ischemia, necrosis, and the liquefaction of the affected part of the lung. and this will result in multiple fluid-filled cavities. Later on, the fluid is expectorated and you are left with air-filled cavities. What is very important in this disease is that it is a self-limiting process. If you give the patient adequate antibiotic coverage and the fluid replacement, and you take care of your patient, this disease will regress totally in the range of 40 to 60 days. Then we do not know why this disease is regressive, since it is necrosis, and this is a peculiar finding for the pediatric patients. Then I will show you some of the cases, and this is an example. A child 2.5 years old with consolidation, and after that he developed cavities, and later on there is complete resolution of the disease. And this is one of my cases I have seen in the pediatric hospital, and I see the patient at that time, where the chest X-ray showed that there is marked expansion of the right lung with complete disorganization of the lung parenchyma and the shift of the heart and the mediastinum to the opposite side. The CT scan of the patient confirmed the diagnosis of the findings in the plain X-ray. The left lung is good, but the right lung is totally disorganized. It is transformed into cavities with multiple necrotic material inside these cavities. But the initial radiograph of the child showed that there was only consolidation of the right upper lobe. Then the follow-up chest X-rays of the same case showed that there is considerable regression of the pathology in the right lung, and this last X-ray showed almost total resolution with a regain of the normal appearance of the right lung in spite of the presence of some pleural collection. This is very important to know, since whenever you are confronted by a case like this with a patient developing pneumonia and rapidly developing cavities inside the pneumonia, then some of these patients were subjected to pneumonectomy, since the clinician suspected that this lung is a totally destroyed lung. It will not heal after that, and they performed pneumonectomy for some of the cases. Then some of the patients who were treated conservatively showed these very good results. So we can save many cases from this hazardous surgical maneuver. And we may talk about one of the lesions which may simulate pneumonia, which is the pulmonary sequestration. And you know that we have two types of pulmonary sequestration, the intralobar type and the extralobar type. The sequestrated lung segment is a non-functioning lung parenchyma which is not communicating with the tracheobronchial tree. And the basics for diagnosis of pulmonary sequestration is the presence of a anomalous systemic arterial blood supply from the aorta to the sequestrated lung segment. And these sequestrations are commonly asymptomatic, but sometimes they may present by recurrent infection in the same site of the sequestrated lung segment. And you see here a chest X-ray, and it may predict that there is some opacity related to the right cardiac border, and the CT scan showed that there is an opacity in the lower lobe, and very importantly, this opacity, there is a branch which is coming directly from the aorta to supply this particular area in the lung, confirming the diagnosis of pulmonary sequestration. Then the pulmonary sequestrated lung segment is commonly seen in the left lower lobe, but also can be seen in the right lower lobe. And sometimes it can see in the upper lobes as well. The diagnosis depends on the presence of a systemic blood supply coming from the aorta to the lesion. And the separation between the two types of sequestration depends on the venous drainage. Intralobar sequestration will drain into the inferior pulmonary vein, while extralobar sequestration will drain to the inferior vena cava or the systemic circulation. And here is a good example of pulmonary sequestration. You see an opacity in the left lung base, and the aortography performed by CT showed that there is a branch coming directly from the aorta to the lesion, confirming the diagnosis of pulmonary sequestration. And you remember we have four focal pulmonary lesions, the nodules, we have finished the masses, we have finished also the batches, we have finished now, and we are left with the cavities. And I have mentioned that the cavity is an air containing lesion, well defined, and it uh, may contain air fluid level or may contain air and mass, but air is an essential feature for the diagnosis of a cavity. And the differential diagnosis of cavities in the lung depends on the wall thickness. If the wall is thick like this, then you are dealing with a chronic lung abscess. But if the wall is thin like this, then look at the site of the lesion. If the lesion is within the pulmonary parenchyma, you are dealing with an hematocele. If the lesion is peripherally located subpleural in position, you are dealing with an emphysematous bulla. And you remember that air fluid level in the cavity will lead to the diagnosis of a lung abscess or an infected nematocele, considering that the air fluid level is straight. But if you see that the air fluid level is wavy or lobulated, and this is what we call the water lily sign, and this is an indication of a ruptured hydatid cyst. And if you see a cavity in the lung with air fluid level, most commonly this cavity will represent an abscess, and the air fluid level will be straight. But if you see that the air fluid level is wavy, then you think that this is a hydatid cyst that has been ruptured. And this is a typical example of a lung abscess with a straight air fluid level in the right upper lobe. And thank you very much. Alhamdulillah Rabbil Alamin.